Good evening, guys. This is Dr. Ashok from Chennai, and I'll set things rolling with a talk on surgical anatomy of the pelvis and acetabulum. The learning objectives for this lecture would be to discuss the key points in anatomy and development of the pelvis and acetabulum. We'll try to understand the important aspects of osteoligamentous and neurovascular anatomy of the pelvis and acetabulum, which are pertinent for treating these injuries. The bony anatomy of the pelvis consists of two innominate bones which are formed from contributions from the ilium, ischium, and pubis, and there is a sacrum in the middle as a keystone. The acetabulum is in the middle of an innominate bone, and the acetabulum is formed by contributions from ilium, ischium predominantly, and to a lesser extent from the pubis. There are three articulations, two posteriorly, which are true articulations called sacroiliac joints, and asymphysis anteriorly. The width of these articulations is around 2 to 3 millimeters in adults, but in kids, it can be highly variable. So if you're diagnosing a disruption in kids less than 10 years of age, symphysial disruption of greater than 10 millimeters and an SI disruption of greater than 8 millimeters should arise suspicion of an injury. The pelvic bones as such have no inherent stability. The stability of the pelvis comes from strong ligaments, especially on the posterior side. These articulations along with ligaments gives the ring-like structure to the pelvis and resultant stability. The main epiphysis in the pelvis is the triradiate cartilage, which fuses with the bony acetabulum at 15 to 16 years. However, there are a lot of other contributions which are mainly epiphyseal, and they serve as important attachments for pelvifemoral musculature. They are clinically relevant because there is a risk of injury to them in skeletally immature patients. Avulsion injuries are common because there is a tremendous amount of muscular forces acting perpendicularly across this epiphysis. Functionally, the pelvis is divided into two, the false pelvis and the true pelvis. The false pelvis consists of the sacral ala and the iliac wing, which is filled with predominantly the iliacus muscle. The true pelvis is the deepest portion of the basin, consisting of the pelvic viscera, the genitourinary structures above the pelvic diaphragm. It is lined anteriorly by the retropubic area and posteriorly by the anterior surface of the sacrum and on sides by the medial wall of the acetabulum. The anatomy of the acetabulum, if you look at it, there are 6 main components: the anterior column, posterior column, anterior, posterior, and medial wall, and then the dome. The anterior and posterior column are two strong sheets of bone arranged in a Y-shaped manner, which connect the acetabulum to the SI joint by means of a strong sheet of bone called the sciatic buttress, which is often preserved in an acetabular fracture and often serves as a constant fragment or a keystone to base your acetabular fracture reduction upon. The acetabular cavity has a specific spatial orientation with regards to other portions of the pelvis. It is inclined at an angle of 50 degrees with regards to the horizontal plane, and it has an offset anteriorly of 15 to 25 degrees with regards to the sagittal plane, which we call as anteversion. If you look at the articular surface of the acetabulum, it is lunate shaped, consisting of a smaller anterior on and a bigger posterior on. The dome is predominantly contributed to by the posterior on. There is also an acetabular fossa inferiorly, which has got no articular cartilage. And if you look at the arrangement of articular cartilage in the acetabular cavity, you can see that the dome has the thickest, and as you go down inferiorly, the acetabular cartilage thickness tremendously decreases. Another important structure that you need to remember is the acetabular labrum, which helps to deepen the acetabular cavity and also increases the area of contact with the femoral head. It's got an anterior and a posterior on, which attaches to the transverse acetabular ligament inferiorly. With regards to stability of the pelvis, it predominantly comes from the posterior pelvic ring because it is along the line of weight transmission, whereas the anterior ring merely acts as a strut, preventing collapse of the pelvis. This is important because even in patients who have a smaller or a minor injury to the anterior ring, or even in patients who got exhaustion of the bladder where the entire anterior ring is missing, the disability with regards to mobility and weight bearing is often minimal. So With regards to stability, the posterior pelvic ring is the most important. Thorough knowledge of these osseous anatomy is important if you are going to treat pelvic fractures with surgery, because not every portion of the pelvis is safe and strong to put your screws or whatever kind of internal fixation that you use. To highlight these concepts a little bit further, Gansland described this 3-ring idea, where he described 3 rings, iliac, acetabulum, and obturator, and the periphery of this ring is safe and strong to put your fixation or anchoring points. So if you look at the iliac wing, there are a lot of options possible along the periphery of the iliac wing. In acetabular ring, you can put supraacetabular and infraacetabular screws. On the obturator, there are pubic and ischial corridors. Similarly, Milton Shiprout described his osseous fixation pathways, where he described these corridors as tubes, often curved. So if you want to put straight implants through them, a sound knowledge and technique is necessary. So I'll just take you through to some of the important osseous fixation pathways that you might be able to use in your practice. In the ilium, there are 2. One is the iliac crest pathway, and the other is the AIIS pathway. These are predominantly used for putting your external fixator pins. Of the 2, the AIIS pathway is bigger, stronger, and is more useful to use as an external fixator construct, because it gives you tremendous amount of stability and strength to correct rotational displacements. The second is the anterior column, or the pubic osseous fixation pathway. This is more tricky. There are 2 constrictions, one at the isthmus of the pubis and one at the level of the joint, and it is often narrow and variable. And it can be sometimes very difficult to seat a long straight screw, often small in females. So if you have an anterior ring fracture, anterior column fracture, sometimes you might be able to put in 6.5 screw. Sometimes you might struggle to even put a 3.5 millimeter screw. So you need to really carefully plan this one. On the contrary, the posterior column, or the ischial OFP, is much wider and predictable. The corridor is bigger. To put in a 6.5 or a 7.3 millimeter screw consistently, you can do this either from antegrade or retrograde. The possibility of injuring the sciatic nerve is much lesser if you stay medially. Anteriorly, the parasymphysial OFP is extremely important, because that serves as anchoring point for your symphysial plate. And if you can position your plate and direct your screws carefully, there are possibility of inserting long screws without injuring vital structures. But you need to remember the structures at risk. If you go laterally, there is a possibility of risk to the obturator vessels and the external iliac vessels. If your screws are long, you can injure the urethra, and you also have to keep the bladder in mind. The iliosacral OFP is very, very important, because it is the most common pathway used for posterior ring fixation. It's got a vestibular shape, narrowest at the level of the sacral foramina, and then widens laterally. There are 2 types of fixations possible. One is iliosacral, where you start posteriorly and then go towards the midline anteriorly. This is used for fixing sacroiliac joint disruptions. And then you have transiliac, transsacral option, where you have a absolutely horizontal pathway, which is predominantly used for fixing sacral fractures. You have to remember the structures that are at risk. There are a lot of structures that you can injure when you're using the iliosacral pathway, including the sacral nerve roots, the lumbosacral trunk, the internal iliac vessels, and sometimes even the superior gluteal nerve if your start point is to posterior. With regards to the iliosacral pathway, you need to know about the dysmorphic sacrum. A dysmorphic sacrum can be common to the tune of up to 35% as reported by Shiprout. And a dysmorphic sacrum means nothing for the patient, but as a pelvic surgeon, it's very important if you are trying to fix a posterior ring by percutaneous screw fixation, because the iliosacral pathway in a dysmorphic sacrum is much different than a normal sacrum. In a normal sacrum, in both S1 and S2, you can insert iliosacral or transiliac screws, and the S1 pathway is always bigger than S2. Whereas in a dysmorphic sacrum is different. S2 offers a bigger and a safe corridor than in a dysmorphic sacrum. And at S1, it is not possible to put in a transverse transiliac style screw. Sometimes you may be able to put an iliosacral screw, and sometimes it may be very small to do that as well. Some of the characteristics that you can use to identify dysmorphic sacrum on a CT scan include a rudimentary transverse process at L5, S1, and then you have a downsloping sacral ala, a persistent disc between S1 and S2, misshapen anterior foramina, and then you have the sacral promontory at the level of the iliac crest, which is otherwise normally well recessed in a normal sacrum. And you also have the anterior indentation of the sacral ala, which is quite typical in a dysmorphic sacrum. So these are some of the characteristics that you can use to identify and differentiate sacral dysmorphism from a normal sacrum. So leaving from the osseous anatomy, you need to be aware of the pelvic neuromuscular anatomy as well. The pelvis is supplied by contributions from the lumbar plexus, sacral plexus, and also from the lumbosacral trunk. The pelvis also has a rich arterial supply coming from the iliac system, predominantly the internal iliac branches. The venous anatomy of the pelvis is also important because this is the one that commonly bleeds in an exsanguinating pelvic fractures. And some of these structures often represent structures at risk, either at injury or during surgical means. And you need to know where it bleeds from so that you can treat this patient successfully. If you look at the incidence of pelvic fractures, 15 to 13% of them have hemodynamic instability, and 8% of patients have lumbosacral plexus injuries. And if you look at the mortality rate, it goes up to almost 60% if you have a bleeding pelvic fracture. So you need to know where the bleeding comes from if you need to stop it. Most often the bleed comes from venous system and the bony and the fractured bony surfaces. The presacral venous plexus is an important source of bleed because it is intimately in communication with the anterior sacrum. And this is one of the reasons why a strategy of using an external fixator with pelvic packing to provide pelvic tamponade has emerged as a treatment of choice in treating bleeding pelvic fractures in the Western world. And this has reduced mortality to the tune of 20% compared to previously. Arterial bleeding can happen in pelvic fractures around 15%. Most commonly comes from mid-sized pelvic vessels, often from the superior gluteal and sometimes from the obturator artery. So this is one of the reasons why therapeutic angioembolization is not the first choice of treatment in many of the Western countries. Some of the other structures that I will touch upon include the lumbosacral trunk, which is contributed by the L4 and the L5. It is clinically relevant with regards to anterior approach to the sacroiliac joint because the lumbosacral trunk crosses from medially to laterally from in a superior to distal direction. So whenever you approach the sacroiliac joint, you need to be aware of this fact so that you stay lateral to the lumbosacral trunk and avoid injuring them. You need to keep your dissection completely subperiosteal, identify the trunk, and stay lateral to it. The corridor of safety is much bigger cranially than distally. Sciatic nerve is the biggest or the largest nerve that comes from the sacral plexus with contributions from S1, S2, S3, and also from the lumbosacral trunk. It exits the pelvis through the infrapiriformis foramen and stays anterior to the piriformis muscle. But this is not often the case and variations are possible, and you need to be aware of this fact whenever you do a Cocker-Langenbeck approach. And whenever you do a Cocker-Langenbeck approach, you need to make sure that you keep the hip extended and the knee flexed to keep the sciatic nerve relaxed, as you can see here. And the nerve becomes much tenser when you reverse these positions. Another artery of importance that gets injured often, probably the most common arterial injury in a pelvic fracture, is a superior gluteal artery injury. This is common when you have high posterior column fractures when the nerve can be torn or sometimes it gets entangled and it may start bleeding when you start reducing your fracture. So you need to be aware of these facts because when this vessel gets torn, sometimes it can get backtracked into pelvis and the bleeding can become uncontrollable from outside. Another possibility is there is a possibility of the superior gluteal artery getting injured during the external iliofemoral approach. This was a paper published from North America where they reported that the approach is quite safe and they did not encounter a lot of injuries when they did the approach. They encountered only one thrombosis and no direct injury in about 41 cases. So pretty much safe there. Another possibility is when you put those percutaneous iliosacral screws, Corey Collins reported around 18% incidence of superior gluteal artery injury based on a cadaver study. And he also said that most of those injuries we don't know because there is good tamponade because the technique is percutaneous, and most of the times the screws themselves provide reasonably good tamponade. Lastly, a word about corona mortis. Corona mortis is a communication between the obturator and the external iliac or the inferior epigastric system. The communication is often venous and small, but sometimes large arterial connections are also possible, and they can lead to significant bleeding if you are not aware of it when you do your anterior intrapelvic approach. So when you go laterally from the pubis, you need to be aware of its presence. It's often situated around 3 to 7 centimeters lateral to the pelvic tubercle. So you need to be aware of this fact when you extend your approach laterally. So to conclude, sound knowledge of the osseous and the neuromuscular anatomy is important to treat these pelvic injuries safer and in a sound manner. Thank you.